Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Hi to everyone who is joining us on the Own Your Heart Health podcast today. I am super excited about a guest that I have today. She is really someone that opened my eyes to an extraordinary new opportunities in preventing one of the most dreaded diseases that we are encountering in our contemporary society, the one that everyone is afraid of. And no, I am not talking about cancer, and I'm not even talking about heart disease, but I am talking about Alzheimer's disease or Alzheimer's dementia. And so my guest today is Dr. Winnie Pak. Dr. Pak has a very deep footprint, as I would say, in neuroscience, as well as in clinical strategy. And currently, Dr. Pak is actually the head of medical affairs for a company that is breaking new ground in the testing for Alzheimer's type dementia. She's the head of medical affairs at VeriBIND, and she brings her tremendous expertise in neuroscience, in clinical strategy, in complex phase 3 clinical trials execution, really bridging the scientific rigor with practical strategic implementation. And so welcome, Winnie, to the show.
Oh, thank you so much, Regina. It's so very nice to be here. And, most of the time my hat is medical affairs. So education and really going out and speaking with those who are interested in this topic. A lot of times people don't even realize what is important and what is already out there. And a lot of the things that we hear about is sometimes, decades old information, right? So we've made huge strides in Alzheimer's research. And so even within the last couple of years, just the diagnostic tools that's around now, most people haven't even heard of. And so I am super happy to join your podcast.
Excellent. Well, thank you so much. And I have to tell you that I sort of, being a cardiologist, of course, we always think about brain, right? We think about brain, we think about kidneys. That's, part of the cardiology universe. But when I became more of an integrative cardiologist and a functional medicine physician, I realized that these common root causes that are driving awful non-communicable diseases, heart disease, of course, is top of the list, or cancer, and even Alzheimer's disease, there is such a huge overlap between these root cause drivers that it's almost impossible to speak about one disease without the other. And the heart and brain connection is extraordinary on many levels. It's a vascular connection. The pathophysiology is vascular. So I'm sort of beginning to understand this, and what we do a lot for our patients. We have home-based testing called Heart and Brain Toolkit that they can certainly test themselves for. But what I wanted to start with is that tell us first, the question I ask all of my guests, how did you grow up to be a neuroscientist? How does one become a neuroscientist? And what was your arc in your situation?
Oh my gosh, it's a very convoluted path that I took. So I actually, for undergrad, I did biochemistry and psychology. I was really interested in both. And then around the same time, my grandmother came, she came down with Alzheimer's, but we didn't really know what was happening then. People threw around the term Alzheimer's. And this is back in the late 90s, early 2000s, where there really wasn't a diagnosis per se. And so until, post-mortem, that's when if you look at the brain, they have plaques. Then that's what they have. They have Alzheimer's. So, but what we knew was, her cognition was going, downhill. She actually had, when I look back now, she actually had a lot of hallucination and delusions that
Wow.
came with, dementia related agitation and things like those types of issues. And so she actually went into the nursing home because my grandfather could no longer take care of her himself. And so I started thinking, well, wow, like what is happening with grandma? And so it really started me thinking like, well, I'm really interested in psychology. I'm interested in kind of the background pathophysiology of diseases. Why not combine them? And so I went into a PhD program for neuroscience, and here in at UC San Diego, which I could not leave San Diego. I am still here. So I got my PhD in neuroscience, and then also did a postdoc fellowship here at the Salk Institute. And then after then, I decided, well, I need to somehow pair this with something a bit more tangible.
Like a clinical application of your knowledge, right?
I loved basic science. I mean, it really was driving, like discovering something new is in itself, the main driver for researchers, and that there was something really special in that. But then there was something missing for me, and it was more of the application of it, right there, that translation from basic science into clinical science, where the community, the society can actually benefit from all the amazing science that comes out of research. And so I started in industry on the drug development side. And
okay.
So, yeah.
Or as they say, you crossed to the dark side.
I did. And yeah, it was actually at that time, my advisor really was against it. At that time, UCSD had the #1 neuroscience program. And so the pedigree for those folks were like, why would you waste it in going into the dark side? Right? You have the pedigree to go and really, do cutting edge science. But there was this missing for me that I really do want to do that translational science. And so I had exposure to drug development when I was even an undergrad. So I did summer internships at Genentech and actually multiple summers. And so I had the exposure and I really enjoyed it. And so I started my dark side career, and and that was over 20 years ago now. And I'm really dating myself, but and at that time there really wasn't a whole lot in the Alzheimer's space. And so I actually did a lot of work in Parkinson's, and worked on a drug for Parkinson's psychosis, which it is now approved. And then I went into rare diseases. It really opened my eyes to how do we really give a voice to folks who don't really have one, especially in the scientific space where, let's face it, drug development is a for-profit institution.
Yes. Well, that's the dark side, right?
Yes, right. And, I think the majority of the people that I work with that I know and are still in the industry, they go in with the right idea. The motivation is to help society as a whole. How do I bring science to the masses, right? And so, the rare disease side is something kind of unique, right? Because there aren't a lot of folks, hence rare diseases, right? But there are a lot of different rare diseases. And so as a whole, rare disease is a huge sector that is not being addressed. And so that really spoke to my heart as well. And so I worked in that for a few years. And then I got approached by a company that said, we really need someone to head medical affairs for Alzheimer's. And then I'm like, oh my gosh, that brings me back to
the
my
circle
original.
has closed.
Exactly.
Yes.
Exactly. And it came full circle for me. And that just really resonated with, kind of what I wanted to do in my heart. And so, and that was a few years ago. I say a few, it's, a few is just kind of like the nebulous kind of adjective, but like it's always been in my heart to be back in Alzheimer's. And this is where I want to be. And
So
this is where
that's your purpose, right?
that's my
Here's your
purpose.
purpose. And to be honest with you, I can fully relate because in my family and my mom's side, a lot of them lived into 90s and even 100s.
Wow.
My great grandmother was 102, but a lot of them also had Alzheimer's, dementia. My grandparents, my grandfather had a very mild form, but and that's always sort of was part of our family history, right? That there's Alzheimer's type dementia. We had relatives affected who are older relatives, and sort of like, what is it, why is it? But as a physician, I'm coming into it as a clinician because obviously my sort of bread and butter is seeing patients, treating patients in a holistic, integrative, comprehensive way. And some of our patients, they are seeking our services because they have mild cognitive impairment and they've been diagnosed with Alzheimer's type dementia. But what I'm seeing is that despite such a tremendous accumulation of resources and research, we haven't really meaningfully moved the needle on Alzheimer's disease. Can you give us your perspective? What is this related to?
Uh, that really is the point. And so I came out and started my own consulting company because that needle is not moving very quickly.
Right.
And that's partly because of the inertia that we've had for decades, right? And so like I kind of started out with saying, back when my grandmother had Alzheimer's, and it was never confirmed because obviously we didn't have to, she passed away. But back then there really was no real diagnosis in life. And our docs were trained kind of with that in mind, right? Well, what is the purpose? Diagnosing them now, there's no treatment. And so that there really is that momentum, like, well, why should we diagnose when there's no treatment?
Mm-hmm.
So there's still a lot of that in the system, where
the bias to diagnose patients.
Right. And the front line folks, the primary care physicians who see the most of these patients, where they go, maybe in their annual checkup, doc, I'm noticing something not quite right. And they have not ever been trained to recognize the early forms of Alzheimer's, right? Or any type of neurodegenerative disease where it's affecting their memory, cognitive function, where they're like, well, it's just part of aging. And so like most people believe that, okay, well, I'm just getting older. He's right. Or she's right. I don't have anything to worry about. It's just going to be the way it is. Well, they need to know how to recognize and kind of stratify. Yes, this is, regular aging, and that's totally normal. Or, well, maybe, but there might be something there that we need to follow up on. Let's see what that is, and we can rule out everything, right? So once we rule everything out, then we're comfortable saying, well, let's just keep an eye on it. But unfortunately, the latter part is what we now do. Like, well, let's just keep an eye on it. Well, this is a progressive disease, right? So, next year when they come back in for their annual checkup, they might be a very different person.
Right.
Because the progression of the disease has now, really accelerated, because we now know the progression, the pathology of Alzheimer's could be around for 20 years before symptoms show up.
So tell us about that. You see, this is what I'm struggling to understand, right? Because I'm also, trained in many ways conventionally, right? And doing, mini mental status or MOCA assessments, and, maybe doing some imaging. But this is sort of like what shook my world when I spoke with you first, because you said, hey, that could be in person's brain 20 years before disease happens. I'm like, whoa, what? This is pretty scary stuff.
It is. And I mean, like, kind of like analogy for like a cardiology space, right? I mean, like, say plaques in your arteries, those are around a while, a long time before someone, might suffer from a heart attack or a stroke or anything like that. So it's very similar. And I always say, I'll come back to this later, but what's good for the heart is great for the brain.
That's right.
And like you said, we are just one machine, right? Everything is connected. If we take care of the machine, keep it tuned up and oil changed and everything else, like it is going to take care of us, down the road. And, if we're lucky enough to live to our hundreds, like your family line, how do we keep our brain healthy? Right. And so going back to your initial question about, what does pathology look like in the brain? So we start worrying about Alzheimer's when we're in our 70s, 80s, but it shows up much earlier if you have the pathology. So the two hallmarks of Alzheimer's, as many of us know, but I can kind of go in the high level, is amyloid plaque, which most of us have heard about. And then the other is tau tangles. So these two hallmarks of Alzheimer's have been discussed and talked about for, decades and decades. But we found out quite early on that we can identify amyloid plaque in the brain at least 20 years before.
Before clinical symptoms appear.
20 years before clinical symptoms.
Before clinical symptoms.
And so, the first kind of diagnostic we had was PET imaging. And so, before it was postmortem, how do we diagnose it in life? And the PET scan, amyloid PET scan, was the first that came out, and like, amazing. We can actually see the deposits of amyloid in the brain. And then came CSF. It's a little bit more invasive, right? You need a lumbar puncture. And so both of those formats can give you very definitive answers that you have amyloid in the brain. And you can see those 20 years before symptoms appear. But we also know now that amyloid, however, it is an absolute hallmark of the disease. It is more of a risk factor. Now, I'm not saying, you have, it's a little bit of a risk factor. It is a huge risk factor, and you do need it for, you need to be amyloid positive in order for a diagnosis of Alzheimer's disease.
So this is important because, in many ways in cardiology, we know, for example, hypertension, dyslipidemia, smoking, these are very powerful risk factors for heart disease, of course. They also overlap with Alzheimer's, but not every person who is hypertensive or dyslipidemic has clinical manifestations of coronary disease, right? Very often they're subclinical. They have plaques. Plaques could be stable. So how do we reconcile this with every person? What is the degree of accuracy that, let's say, if a person says, oh my goodness, they can see amyloid in my brain 20 years before anything at all, how accurate is this for, let's say, forecasting that at a certain time point, a person may actually develop cognitive impairment? Sort of what is the risk associated with having amyloid in the brain?
Right. And it really, it sucks to say, but it really does depend, right? It depends on this whole nature and nurture. So if you have a genetic predisposition for Alzheimer's, so there are a few, and the most well-known is the ApoE4 allele. And you are obviously, in cardiology, that's also a very important risk factor.
Very important. And we test for it all the time in all of our patients.
Yes. And when we discussed it earlier, I think in the cardiology field, I think you guys have been testing it for way longer than the neurology field, even though we realize that it is a huge risk factor. So someone who has one ApoE4 allele is about 3 times more likely to develop Alzheimer's. And if they have both alleles, if they're ApoE4, then they're up to 15 times more likely in developing Alzheimer's. Now, but that is not 100%. That is not fully penetrant. So there are genetic mutations that does pretty much guarantee you getting Alzheimer's, and that is these presenilin mutations, and that's very rare. And so, but they are being studied. But in the general population, the most recognized risk factor is ApoE4. And, so setting those aside, even that is, it's not rare. So to have one copy there, it's probably, 2/3 or so of us have a copy. But the most common allele is ApoE3. And then you're just kind of at the baseline level of risk. And so that's the nature side. The nurture side is really, and, we brought it up, what's good for the heart is great for the brain. So exercising, sleep, keeping your blood pressure in check, your A1C, making sure your blood sugar is stable. All of those things are great for your brain. And so there are multiple lifestyle factors that we control, that we have a hand in, have a good say in how that progresses, right? And so with all of that, yes, pathology can show up, 20 years ahead of time. But there are people who, if you look at some of the centenarians, they do have amyloid in their brains.
Yep.
But they have resilience factors that we in science have not quite identified yet. But, all of these lifestyle factors do come into play, right? And the Lancet Commission, one of the commissions is on dementia prevention. And so they publish it every, 3-4 years or so. One came out last year, identifying 14 risk factors or modifiable risk factors that can actually decrease almost 50% of dementia cases. We can get rid of 50% of dementia cases if we address these 14 modifiable lifestyle factors. And those are not trivial numbers. I mean, that's half of all cases that we see. And so things like, exercise, of course, we know that. Managing your blood sugar, alcohol. We don't like that, but it's, so the commission really looked at really only identifying those factors that have robust scientific data backing it. So these are not just kind of, we heard of a study here, we heard of a study there, then we're throwing it in. But these are what the commission decided have really strong evidence to say, hey, if we take care of our hearing, we get rid of I think it was 7% of dementia cases. And so education was a big part as well. And so, keeping our mind going,
engaged,
right? Staying curious as we're, getting older, learning something new. Those are all things that, play into this resilience factor that, we haven't quite scientifically isolated, but there is something that we can do in our lives that all factor in to our risk. And so absolutely, if we find amyloid in your brain, it is not an absolute guarantee that you will develop symptoms. And so amyloid itself is a huge risk factor. Now, what we now know is tau is a much more deterministic factor.
So what is tau? Maybe if you could educate our listeners, what is the difference between amyloid and tau?
So they're both in our brains. They are normally, existing proteins that have very important functions in our brain, both in development and as we age. So amyloid, in its form that is normal, is upregulated when there is any type of trauma, stress. So amyloid gets upregulated. That is an absolutely normal process. What is abnormal is when it misfolds. And then it starts sticking to each other. It's a very sticky protein. So then the brain, when it starts sticking to each other, the brain does not know how to get rid of it. So it kind of sticks around the brain. So the normal processes of removing it from the brain and getting rid of it that part of the mechanism is now slowed down as we age. And then this process of these misfolded proteins sticking together, it just gets bigger and bigger. And now the brain is like, oh no, what am I going to do with all these things that are floating around and I can't get rid of it? Well, let me just kind of package them away and stick them, in a corner somewhere. Kind of when we clean house and we have a visitor coming in, stick everything
We'll hide it.
We'll hide it. We'll put it away in the closet and we'll come back to it later. And that's kind of how I envision the brain, what the brain is doing with plaque. So now there's all these things all these misfolded amyloid proteins that are around. What do? We can't get rid of it. Let me just package it and put it somewhere. And so sequester it into a plaque and then kind of put it away and kind of keep it away from the normal functions of the neurons and glia. Well, tau, so that is outside of the cell. Amyloid is outside of the cell. So tau is a protein that is very important for the structure of cells. They are part of the microtubules, the scaffolding of cells, the transport of materials within cells. Those all depend on the tau protein. Now, again, once it starts misfolding and the conformation of the protein is not what is normal, that's when the cell goes, oh my goodness, now we need to get rid of this. Now we're kicking out these tau proteins. Now what happens with them? And so they can't kick it out fast enough. Then they start forming these tangles. Now, so the tau protein gets hyperphosphorylated. So they get modified in the cell and then no longer performs its function the way it's designed.
So it's stuck inside the cell, not performing its functions, not really helping the cell to maintain these transport mechanisms or structural integrity. It sort of just, piles on as an obstruction to normal function.
Right. And to the level where at the end of the day, you end up killing the neuron or the cell that has the tangles. And so, but we now know that some of these get secreted and it gets into the blood. And so it gets into CSF, that we can detect it in CSF. And then we can also detect it now in plasma as well with a blood test. And so there's lots of things going on that is happening in the brain that we don't really know, right? So these are things that we have found out we can detect. What else is kind of the context around all of that? We're still trying to figure out, there's lots going on, but we can only have snapshots of, what is happening in the brain, right? We don't have a continuous monitoring of what is happening, all the different processes. We have, various snapshots of what is happening in the brain.
We're guessing basically. And so sounds like when tau, and there are several commercial assays for phosphorylated tau, right, which I'm sure you're going to go into it, but based on what you described, it sounds like when this phosphorylated tau is detected in the bloodstream, this is sort of, the train sort of left the station, right? It means the cells have already gone through this very damaging process. Their structural integrity has been compromised. And now tau protein is basically leaking, even penetrating blood-brain barrier, going into the circulation. So this is sort of not a great development for sure.
Right. And so a paper that got published just this summer, and this is all relatively new information about tau. We are learning a lot. And so the paper that came out this summer using a tau PET scan indicated, so they looked at a large population. I don't remember, several thousand. And they looked at once you become tau PET positive, so they do a PET scan and you're positive, within 3 to 5 years of that positivity, symptoms appear. And it's a large population.
So it was population of healthy individuals who at baseline did not report cognitive impairments.
So within the cognitively unimpaired, they transitioned from unimpaired to a mild cognitive impairment diagnosis within 3 to 5 years. And then they also, for those who were already in the MCI stage, they progressed to the next stage of mild AD within that similar time frame. So these are very important findings, right? Because now we have something that is pointing to something that is not just a risk factor. It is much more deterministic than, well, you have an increased risk. Now that, within 3 to 5 years, that's, depending on how you look at it, that's a short time. And
it's a very short time.
Right. And might we be able to kind of still slow down that progression? Right. Now, there's studies that also came out with the pointers within the US that really looked at structured lifestyle modification that were significant, right? That they were able to show significant slowing of progression of disease, just straight lifestyle modification, exercise, eating better, and all of that. And so all the things that we know to do, but until there's more of a fire under our butts, we don't take it seriously. And I think it is time that, we really take our heads out of the sand. And because a lot of people still think that, well, why diagnose? There's nothing I could do about it. That's not true anymore. And
that's right. That's a huge myth, because even speaking with US pointers, I think we wrote about US pointers. I wrote in one of my newsletters, I think maybe in August issue of the Holistic Heartbeat, US pointers study was in many ways groundbreaking, because what it showed is that a structured program that actually gave people resources and held them accountable was hugely impactful for patients with mild cognitive impairment. It was just such an enormous achievement that it wasn't a drug. It wasn't anything too outrageous. They did give, they had a little bit of, the control group had a little bit of help also, because they had like a small, I think, stipend for getting fresh foods and things like that. So, but it's truly a testament, I think, to the impact of lifestyle interventions. It was definitely, a study that I always cite with my patients so that they understand.
And I mean, I think what it did was really just gave numbers to what we all already knew. Like we knew if we just took better care of this machine of ours, it will, pay back dividends. It will take care of us. But now they were able to show it with scientific rigor that this absolutely does make a difference. And how awesome would it be if doctors write that as a prescription instead, right?
Lifestyle prescription.
Right. And, healthcare systems really take it seriously that, if their docs just write a prescription and have programs that go, okay, well, our gym is right there, next building, and you go there 3 times a week or 4, like whatever the structure they have put together, that is a prescription that they give their patients. How amazing would that be? And and I think that's kind of ultimately our goal, right? To kind of transition our current kind of sick care system into a true healthcare system, like really taking care of our patients and preventing diseases instead of reacting to diseases.
That is so true. And I think very often what happens here, Vinny, is that patients or physicians think that there have to be these very complex interventions that need to take place. And they fail to recognize that there is low-hanging fruit, that you don't have to do everything at the same time. Even if it's just increasing your daily steps by 1,000 per day, well, guess what? It leads to a 15% drop in cardiovascular mortality. That is tremendous, like it's better than a lot of medications that we're actually using.
without side effects, right?
Without side effects, right?
Yeah.
And I just, I'm going to plug in the Holistic Heartbeat newsletter. You can, anyone who's listening, you can sign up straight from our website. We actually, and you will find the issue. We only release it once a month. You'll find the issue where we actually discuss, the new data with regards to mild cognitive impairment, the impact of lithium, and the US Pointer study, and we sort of go step by step what they did and what they found, and how it worked, because you can then hopefully implement at least some of these strategies for your own heart and brain health. And Winnie, I want to shift gears because, what you're describing, honestly, I have to say is scary to me as an individual of someone who has, family history of Alzheimer's, probably scary to you as an individual who has family history of Alzheimer's. So what are the new opportunities? Because I know that, you and I spoke at length about an opportunity where we can actually detect some of those earlier changes before we see pathology sort of to start consuming our brains, right? Because both the tau PET and even phosphorylated tau and amyloid imaging, it detects the damage that is already happening, right? So what can we find before such extensive damage is actually taking place?
Right. So that's a tough one, right? Because the way science works is, well, we want to make sure that everything is safe before we kind of, make it available to the general public. And so most clinics now, they really don't have any tools until the symptoms appear. A lot of the phosphorylated tau species that are in blood tests right now, they're only indicated for symptomatic patients. And so if you say, well, okay, I something isn't right, and then the doctors do their memory tests and they actually give you a diagnosis. That's when then they can order these tests, because it is only indicated for symptomatic patients.
So sort of disease activity checker, right? At that stage, it's not really predictive of disease development. It's a disease activity checker. It's sort of like, checking cholesterol once a person has a stent.
Yes, exactly. And that is basically what they call like an aid in diagnosing, right? Because before these tools became available, patients really diagnosed Alzheimer's and other dementias based on their clinical diagnosis, straight clinical diagnosis. And we now know, kind of going back and looking at the data, clinical diagnosis is only accurate about 2/3 of the time.
I'm surprised that it's even accurate 2/3 of the time. I would expect it 1/3 of the time, but hey, 2/3 is not so bad.
Yeah, and it's about 70%. I think they're accurate, and so that's not good enough, right? Now that we have these tools, let's utilize these tools to help supplement the clinical diagnosis. And so what these assays and scans really do is really help the clinician be more confident in their diagnosis, right? And so that they're designed to be complementary. So once you have like a clinical diagnosis, you're like, okay, well, let's confirm that with these biological tests. And so there's the clinical diagnosis and then the biological diagnosis. And so one of the more exciting things that you and I talked about, because now we have 2 drugs that are available, and this is just the first 2 drugs that are available. Well, there's 3, but that's another conversation. But there's 2 that's available now to patients who are in the mild stages of the early stages of Alzheimer's, the MCI and the early AD. So now there's a huge push to identify patients who are early enough in the progression of the disease that they can benefit from these drugs, right? And because once they move into the moderate stage, they are no longer indicated for these drugs, because there are side effects that end up being more relevant for patients who are further on in the
further along.
And then the benefit risk ratio is no longer in favor for the patient because there are risks, right? And why suffer the risks when you're really not getting the benefits any longer?
And so, also at that point, I feel like once even patients with mild cognitive impairment, having worked with some of them, it is challenging for these patients to execute on the lifestyle effort, right? Because of their cognitive impairment. But
absolutely.
Once they become more advanced, that becomes even more difficult by orders of magnitude. So, to really execute on a fairly complex strategy or even as simple as possible lifestyle strategy for mild cognitively impaired patient is difficult, but not impossible. With the moderate impairment, it's pretty much not really doable, at least not in a way that will be sustainable for patient and their family.
Absolutely. And that's when we start seeing the uptick in the nursing home care, the requirement of advanced care, right? So how do we slow that down? How do we extend that period? Even, obviously the goal would be the cognitively unimpaired and where patients never see a symptom. But what if we can actually even just slow down the progression, right? Which is what these two drugs are able to do. Now, these are the first generation drugs. It is better than nothing kind of realm, right? They're slowing down the progression by about 30%. Now, a lot of folks are like, well, that's nothing. That doesn't. Well, you know what?
I'll take small.
30. Yeah, I'll take 30% over 0%.
Of course, right? Of course.
But that doesn't come with, it does come with side effects. That's the issue, right? And so it is a risk benefit ratio that you have to consider as a clinician, partnering with the patients themselves and their care partners, like decide, is that a risk that you're willing to take? And sometimes it's not, right? And that's a decision that the kind of the care team makes together. But now speaking of, how do we actually now target and identify patients earlier and earlier on in the progression stage, right? So like where, okay, it's great that we can identify early Alzheimer's. It's great. It's even better if we can identify mild cognitive impairment. Now, if we can actually identify those who have the pathology and are on their way to developing symptoms, but currently unimpaired, how do we access those patients? And there are trials now that are ongoing, recruiting for patients who are pathology positive. So they are cognitively unimpaired, so asymptomatic, but with the pathology. And so these are called secondary prevention trials because you have the pathology. We haven't prevented that, but we're going to try and prevent the symptoms from coming on. So obviously we would love like something like a vaccine where we would never get it. That would be great. Right. And so those are actually ongoing.
Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol. Then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is OWNER20, and I'll see you in the office hours. You have a very interesting, with VeriBIND, you have a very interesting opportunity to actually do exactly that, what you just described, right? Identify patients who may have biological pathology early, but they're cognitively unimpaired, and it's sort of, identify them early in that, what one would call subclinical stage, right? Which is in cardiology, we do it. We have a ton of great imaging tools, but you now have an opportunity to do that in Alzheimer's dementia. So what is it? Tell us.
Exactly. And I touched on it earlier in the beginning of the podcast about a tau PET.
Mm-hmm.
So there are the identifying amyloid and identifying PET, and PET is the more deterministic factor. And what this assay actually does, it provides a test in blood. So something that most patients are, familiar and comfortable with, getting a blood test, right? And so what the results of the assay actually tells you, and it basically recapitulates what the results would be from a tau PET. And so now we know, like a tau PET, if you're positive, 3 to 5 years, you're going to start developing symptoms. What this assay does is it gives you the same idea, the same result. So if it is positive, that it completely translates to what that tau PET actually will tell you as well.
More likely to show.
Exactly. And so the assay has been validated against a tau PET. So it's 90, 95, 96%, exactly the same thing. So if the results say you are tau PET, you are positive in this VeriBIND tau assay, you are very likely also positive on a tau PET, 96% or so. And, wow. And so for a tau PET is actually quite expensive, and it's not approved in, for with insurance. So all patients pay out of pocket. And most of these assays now are out of pocket for most patients, unfortunately, until, CMS and a lot of the insurance, because it is relatively new and people need to be more comfortable with what the results tell you. And so right now, most of these assays are not paid for by insurance. And so it is out of pocket, and including this particular assay as well.
So Winnie, what does it measure actually? So it's a blood test, right? We do peripheral draw like you do for any other blood test. What does it actually measure? Because this is a pretty powerful measurement, right? 95% accuracy versus tau PET. Now, I'm a cardiac imager by my early career, and I still am. I'm a huge fan of PET. Actually, nuclear cardiology was my main pursuit for many, many years. So, so of course, know everything about PET scans, but, tau PET is a tissue imaging type of a test. So it's an tissue diagnosis of pathology. And so this blood assay specifically could tell you with 95% accuracy versus the tau PET that there is tau accumulation. But what does the assay actually measure?
Okay. And so to answer that question, I'll give a brief overview of what the tau PET actually gives you. So tau deposits will form. So the first symptom most people would notice is memory issues, right? I'm getting more forgetful. And that's because tau tends to accumulate in around the hippocampus or the entorhinal cortex, where it's more, it stays there for quite a while without really disrupting any other function. So where you start seeing much more lifestyle impacting symptoms is when it starts spreading out of that area, out of the medial temporal lobe into the cortex. That is when your independence and all those executive functions are affected. So the spread of tau out of that area into the cortex is the inflection point. And so MCI around there, it's still, you can see tau deposition in the MTL. But then once it spreads, that's when you start, the patient starts experiencing these executive function losses. And so what this assay does is really pick up that part of the pathology, is the ability of tau to now spread. And so the assay, what it does is it obviously takes your peripheral blood and then it pulls down all these kind of misfolded tau, and then asks the question, is this misfolded tau able to spread? Because you have misfolded tau, and like you can be asymptomatic, right? And that stage can be quite a long time, like 3 to 5 years. But if it starts spreading, you know that pathology is already there. It is capable of spreading. Now, if you're capable of spreading, that means pathology, your symptom onset will be imminent.
Fairly rapid,
right? And because, if it's not spreading, it's just kind of staying put. It's inert. It is not causing too much havoc in your brain. It's staying kind of sequestered. But if it starts spreading, the worry is that it starts spreading into the cortex.
So the power of this assay is to give us this time point.
Yes. And so it gives you that similar time point that a tau PET would give you, right?
And
that pathology is already there. It is capable. The tau in your brain is capable of spreading. Now let's do something now. Does that mean, whatever the families are comfortable with, right? Does that mean lifestyle factors? Does that mean exploring clinical trials, right? Does that mean going on to these therapies that are already available? Understanding what the risks are, and so there are now multiple options for patients. It is not like, the guarantee that's it, you're done. There's nothing else you can do. We can just, send grandma to a nursing home. That's not where we are anymore.
Right.
We have progressed. And it is such an amazing time. I'm so excited that
it sounds like an absolutely amazing breakthrough. And I'm happy to report to our listeners that we are bringing the VeriBIND tau testing into the sort of scope of testing for the Holistic Heart Center as part of our heart and brain pathway. But it is extraordinary that we finally in Alzheimer's dementia are able to move into the domain where we have a bit of time to execute on these preventive strategies. I mean, granted, these preventive strategies probably should have started when people were very young. If you know your genetics, and we test genetics on pretty much all of patients that come to us. But if you know your genetics and you might be at higher risk, obviously these preventive strategies should have started, way back when. But, this is life, and people are not necessarily going to live under duress of potentially having Alzheimer's dementia, even if they have a family history or genetic variant. So this is really helping us to get it at the time point where the interventions are much more likely to deliver a meaningful impact. Would you agree with that, Winnie?
I absolutely agree. And I think at a time point where patients are most likely to actually take action, right?
And still capable of taking action.
Absolutely.
Right? Remember how we discussed that it gets so much harder once those cognitive symptoms get in. They're still capable of taking action at this stage.
Exactly. And early detection really empowers the patients to, make the choices that they can still decide, which path are they going to go down. Right. And so, and a lot of times, like you said, they are able to now decide how they want to progress. At least putting in like family planning, like, okay, insurance wise, like, how do I want to proceed? Like, okay, I've got the pathology. Now I'm going to do everything I can. And then as well, how do I make sure my family is, taking care of me the way I want to be taken care of down the road. And so those are all things that patients are now empowered to be able to do with clarity, right? Because now they know this is a definite path for me, right? This is now, if I can shift that, and they have the power to shift it themselves. Now it's their choice.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. It's extraordinary, and I have to, I can't emphasize it enough how powerful it is to know things before, even if it's only 3 years or 5 years, one can meaningfully shift their risk factors in 3 months, maybe not to the final stage, but at least begin the meaningful changes. And we have such a great opportunity right now with cardiometabolic testing, with metabolic flexibility, with medications like GLPs and GIPs, with hormonal replacement therapy, with peptides. They're not strictly speaking, Alzheimer's type drugs, but they really dig into those underlying risk factors and open the path to optimization. And honestly, it literally puts this in the hands of the individuals to be able to execute on it. I want to finish up with a couple sort of yes or no's or maybe, because, our listeners, obviously they're thinking about, should I, run to Dr. Druz and get this test? So let's think it through. So would you advise, let's say, a middle-aged person who is ApoE4 heterozygote, meaning single copy, would they benefit? They have no cognitive impairment whatsoever. They're a healthy individual doing all the right things that we know we're supposed to do. Would you advise them to get a VeriBIND test?
So let me just couch all of my answers with, it really depends on the person's kind of risk tolerance, right? And
right. Some people may not want to know. I had some patients who say, please suppress my ApoE result. I never want to know. And we've gone ahead and we've done exactly that.
Yeah. And I think the more we know now, the Alzheimer's Association actually did a survey, and almost 80%, I think it was 79% of Americans do want to know if they have, if they will develop Alzheimer's, and they will ask for a test if they have access to it. Even before a doctor would order it, they would ask for it. So with kind of that in the background, I can only say if it was me, right? If I knew I had ApoE4 in my background, do I want to know? And for me, it's a yes.
Right.
I'm a scientist. More knowledge, more information is always better, right? So if I have, then it's my control. I decide how I want to move forward. And of course, there are a lot of people, we've heard stories where people have been, gone into depression because they did find out they were ApoE4 positive, right? And so that has to be balanced. It really does come down to the patient's own desires to, is this going to benefit them? Only move forward if it will, right? Obviously, if you have your oath, how do we best take care of the patients? Is this going to help them in the long run? If they will now take better care of themselves, that's an absolute yes. I would present it to them and say, this is available if you want to take advantage. If this is going to help you take better care of yourself, that's an absolute yes. But if you're not there yet, if you're not in the right mind space, then let's wait, right? Because you have to be because this is not just a simple, a test where, you have the flu, or it's not, it is a pretty, and I have to appreciate that it is a very heavy result. Right.
This emotionally, it's a very heavy result. And, I absolutely respect, patients' right and desire to champion their care the way they wish to champion it. And for some patients, like I said, we have plenty of patients who said, I never wish to know my ApoE result. please suppress it, and we suppress it, and that's it. That's the decision that they're making. But I think I'm a scientist just like you, and I feel like I do worse with uncertainty. And so for me, for my personal brain, for my emotional sort of health, I need to know, even if the knowledge could be not the outcome that I want or expect, but the certainty is being in control is more important to me. It's just a personal thing. But would you, based on what we've discussed, it sounds like if a patient already has mild cognitive impairment, they probably benefit a little bit less from this type of testing, right? Or should they still have it, or maybe at the same time as their phosphorylated tau measurement? Like at what point would you say phosphorylated tau is enough and you don't need to look for these earlier, or test or identify pathology earlier before the symptoms appear?
Well, I do think that at some point, like, does the diagnosis matter, right? If they're, kind of far along enough, unless you're trying to perhaps monitor, like, are any of our interventions doing anything? And so that still tends to be towards the earlier stages of progression, right? Like if we're really, hitting it hard with all the whatever interventions that we can, be it therapeutics, or lifestyle intervention, whatever that be, like, it's nice to have something that'll tell you, am I making a dent in the pathology itself? So the current, more commonly used phosphorylated tau species, like 217 or 181 even, they look at a biomarker, and the biomarker, something like the phosphorylated tau species, they go up and down for various reasons. We now know comorbidities affect these tau measures. And, based on the typical population that would be using these tests, something like, say, chronic kidney disease, hugely affects, the biomarker results. Even, say, like anesthesia, if you've gone in and, gotten a procedure done or anything, kind of stressful in that sense, your biomarker changes. And so something that actually measures your pathology tends to give you a better read of what is actually something that is relevant to your question, right? Not just the snapshot today looked like this.
Right.
And it might not be relevant somewhere, 6 months down the road. Now your baseline is pretty skewed, right? And so to answer your question, yes, there is a point where knowing your pathology at some point, it kind of confirms your idea of, where this patient is. But most of the time, I find that patients who are asking for or more interested in these would be beneficial to get, because it actually allows you as a physician to help them track how they're doing. Because this is currently a semi-quantitative assay. So it'll give you a number, and then if I start, taking on these lifestyle modifications, am I actually moving the needle?
Making a difference. Yeah. Yeah.
Exactly. And so whether or not they take it on themselves, that's their decision. But as a physician, I would think that, giving them that option, that you can now help put some structure to their
to what they're doing.
Exactly. Yeah.
Winnie,
they can have an objective readout for them.
This is an eye opener, and I know for a fact we will be back next year after I had a chance to actually implement this and discuss it with our patients. And, you know me, I'll probably do myself first, because that's sort of like what I do very often. But, we'll go over through the test results and sort of, get more into the kind of what it allowed us to do, what impact it led to. But thank you so much for coming in to Own Your Heart Health. It's been a delight.
Oh, thank you, Regina, for having me. And if you have any questions, and if your listeners have questions, please feel free to shoot them my way, and I will address everything that I can.
We got it. We're taking questions and comments, so please send them here, and we'll pass it on to Dr. Winnie Pak, so that we can learn more about Alzheimer's disease and get to prevent it.
All right. Well, thank you, Dr. Druz.
You too. Bye-bye.
Bye-bye.
Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Card Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Card Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticcardcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.